starting. All attendees are in listen-only mode.
Good afternoon, everyone. Today is Friday, May 22nd. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to the Friday series of DDA updates. Thank you for joining us. We have several presenters today: Bernie Simons, the Deputy Secretary for DDA, Patricia Sestoki, Director of Programs, Rhonda Workman, Director of Federal Programs, Valerie Roddy, Director of Fiscal and Operations, and also with us is Dr. Kenneth Fader, Epidemic Intelligence Service Officer with the CDC, assigned to the Maryland Department of Health for Prevention and Health Administration. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There is one option to listening to the webinar, and that's by computer. There's a handout for our webinar, and you can find it in the handout section of the panel to your right of your screen, and they can also be emailed. We will be recording the webinar and posting it on the DDA website. And so now I'd like to introduce Bernie Simons. Good afternoon.
Good afternoon, and welcome to everybody who's on this webinar. You know, this is a series that we've been conducting to keep people updated on where we are and how we're moving forward with assisting everybody. Again, I hope everybody is healthy and well. We are committed to working with everybody about your health and well-being. And I want to make sure that we keep our communication both ways, from you to us and us to you as the state, to make sure that we continue to try and meet everybody's needs the best as we can, and identify areas where there's maybe needs for some type of improvement and as we move forward, because obviously this is new territory that is uncharted, and these are the times that can be very difficult, and not expecting something or being able to anticipate like we would, since life is not normal. And so, as we move forward, I want to thank you for your ongoing commitment on where we are with the regional offices, and we'll do a status of that. And again, thank Dr. Fetter for being with us again. He's been with us multiple Friday afternoons and been extremely informative with what he has been saying. So again, our highest priority is everybody's health, safety, and well-being. But what does that look like? We know that we've done webinars. This past Tuesday, we did it on self-direction for Appendix K. I believe it was well received. It was an hour-and-a-half webinar. It probably could have even been a little more in length, probably for another half hour, because I think that there was some really good information and some good interchange with the people who were presenting, as well as the questions and answers throughout each section. So I want to talk a little bit about PPE. There's been some comments about PPE, and it's been lacking, and we haven't had much, etc. I've mentioned in the past couple of weeks that for PPE that we've been fortunate enough in DDA to receive PPE, and obviously I just wanted to demonstrate that it may not be the whole universe that everybody gets something, but with the system we put in place, with the request and how to triage that for people who are active or need to isolate or quarantine, including if you have active staff, etc., where we are. So you can see we've given out quite a bit of gloves, masks, and gowns. Gowns have not been as demanding, I don't believe, or from what I hear back from the regions, as the masks and the gloves. So we've had 3 shipments so far. We let the providers know that when the PPE is delivered, and try and get everything out within 2 weeks and schedule that so that people can come in. And we know that many agencies have received multiple orders with those 3 different distributions that we've had. I want to give you a little bit of a breakdown of what one of the regions look like. And so In the Eastern region, we've had about 1,300 gowns go out to the providers, 11,600 gloves, 16,000 masks, and 80 face shields. And that was distributed over 19 residential providers and 40 people in self-direction. So this is not just going to the providers. We're trying to be extremely sensitive and inclusive of our whole system, whether it be people in traditional services or people who are self-directing. If you'll bear with me, I'll do the Western region. It is 700 plus gowns, 20,000 pairs of gloves, 10,000 masks, and that went to 18 residential providers and four people who are in self-directed services. Central, it's basically about the same, 20,000 masks, 20,000 gloves, 2,000 gowns, 60 plus providers so far, and 34 people who are in self-direction. And then looking at the southern region, it's about 15,000 gloves and gowns, 20,000 masks, 46 residential providers, and 33 people who are self-directing. So we may not have 100% of being able to meet everybody's needs, but I think in DDA, we've been very fortunate enough to have multiple pallets of gowns and gloves and masks and face shields come in and be able to notify providers from people who are self-directing so that we can meet people's needs for safety and be able to get that PPE out as quickly as possible. And so where are we with recovery? We know that, and I've mentioned this in the past, and I actually had a couple of comments about why am I talking about reopening when we're still in the middle of a pandemic, and it's basically because that is a national discussion among all of the states, and also even within our state here, we have multiple providers who are trying to figure out what happens as the governor just brought us into stage 1. I don't think we have an idea when we're going into stage 2. He'll make that determination based upon the data that he has. But obviously, we're working with the my counterparts of the State Association of DD Directors, and they basically looking at 4 different areas. Day services, obviously, because that was affected very much with what we have with people being in their residential home or home with families. Where are we with any financial? Obviously, health and safety, and then what we call sunrise, which would be looking at new opportunities for the way we do business. And so those are the 4 areas. We've obviously, last Tuesday, there was the first meeting of the subgroups, and the subgroups are, again, multiple states. And as I mentioned in the past, California, Washington, Ohio, Connecticut, Pennsylvania, Georgia, North Dakota, South Dakota, and Ohio. And so all of those states have had participants in there, and basically looking at what type of surveys or utilization do we need to have discussion about how to set plans to begin to possibly reopen, and what would that look like as far as health and safety, which is the second or the third bullet on here. It's basically taking a look at, so most states, what are they considering? Looking at PPE, social distancing, regional issues within the region of the state, readiness of the providers, cleanliness of the agencies, etc., so that we are in the forefront of health and safety strategies, etc. The Sunrise group is going to be continuing to look at and providing webinars to families and communication, and as we've had in the past, discussion about our waiver services, about blending and grading, etc. I think we're in a much different venue right now with remote technology. I've had some questions from providers about where are we with remote. It seems to be working real well. Can we continue to do this when we get beyond stage 3, when the governor talks about we are reopened? What does that look like? I think that this is a good opportunity for us, especially with that sunrise phase-in group, for new possibilities, new opportunities that we did not necessarily have in the past. I know that we've been doing a lot of partnership with the Department of Disabilities, because they have the point person for assistive technology. We've had discussion with that. We've had providers that we've had discussions with about what does assistive technology look like. We know that, especially in light of the staff shortages that was highlighted in the President's Commission, as well as the anchor report back within the last couple of years. So we need to think about doing business a little bit differently. And I think, from my opinion, it gives people also an opportunity to basically self-regulate and be able to internalize and not necessarily rely on some type of external stimulus as a staff person. And I don't mean that negatively, but, you know, internal control and being able to, again, self-regulate. We know that being able to communicate, more independence, etc. And so, where are we with the regions? We know that we have had people who have had testing positive. We'll just give you an update as of the confirmed cases and the tests, and unfortunately, the number of people who have passed away. So in the South region, there's 184 confirmed cases. There are 55 that were negative, 2 pending, and 13 people who passed away. In the East region, it's 28 confirmed, 21 negative, no pending, and no one has passed away. In the Central region, 89 confirmed positive, 90 negative, 18 pending, and 9 deaths. And in the West region, 10 confirmed positives, 30 test results were negative, no pending, and 2 people have passed away. We know that we've had a lot of discussion about, so what about the direct support professionals, and what does that data look like? In the South region, to date, we have had 100 staff test positive, and we have had 4 people pass away. In the West region, we have had 16 positive and 0 deaths. In the East, we have had 46 staff test positive, and in Central, 92 people staff have tested positive. So we want to be able to make sure that, again, when we go back and talk about PPE, where are we with confirmed positives and pendings, and for staff and participants in the waiver. With that, I will stop, and I'm going to turn this over to Dr. Kenneth Fader, again, who has been assigned to the Maryland Department of Health. He's with the Center for Disease Control and Prevention, and who has been extremely, extremely informative and helpful to us in the past few weeks with his presentations and his knowledge and insights. So, with Dr. Fader.
Hello, and thank you, everybody, and thank you for inviting me back once again. So I'll be much briefer today than I was last week. All I want to say is that you should have seen, or you will see soon, that materials have gone out, and in particular, we sent out 3 things. The first is just a checklist of recommendations for group homes for preparing and responding to outbreaks. I'll just briefly talk about what's in that set of recommendations. And then the other 2 documents are just symptom screening tools. And it's the same tool, it's just formatted 2 different ways, depending on what's easiest for your program. But that's just there to help folks do symptom screening. If you're trying to think, should this be screened for, should this not be screened for, it's a tool you can use. But let me focus on the checklist for preventing an outbreak. So the first thing I want to say is that most of the things that are in here are things we've already talked about, and that by all accounts I can tell everybody is already doing. And so part of this is really just about formalizing the things that most of you are already doing, and getting on the same page about them. And then the other thing is that it's really about helping folks make a plan and understand what resources are and aren't available. And another thing that it is it gets all of us on the same page. So these same recommendations are being distributed throughout the Maryland Department of Health and to the local health departments. And so everybody should be familiar with now the guidelines that you're operating from, and we should be operating from the same guidelines. And another thing I just want to say is, first of all, thank you for your patience, but also thank you for everything that everybody who I've been in communication with has told me and taught me, because all of those things go into this. And it doesn't end here. You know, I'm going to continue to try to join to take questions, and as issues arise and as also new resources become available, I anticipate that these guidelines could change at a later date. And I don't know when that will be, but it will just reflect changing resources and our changing understanding of COVID-19 and how to stop it. Let me just briefly touch on everything that's in here. So the first section of that we talk about is preventing and preparing for an outbreak. So these are things we've all talked about many times, and a lot of them are not prescriptive. They're more about recommendations and reminders about things it's important to have a plan about, or things that you want to be prepared to do right away when the outbreak starts. So I won't talk about each of those in detail. I'll just want to note one of them is identifying a healthcare provider or group of providers who serve your residents and might be able to facilitate collection of respiratory tract specimen in the event that a resident must be tested for COVID-19. So we recognize that one of the biggest challenges, if not the largest challenge programs are facing, is access to testing, and that this landscape can be inconsistent depending on where in the state your program is located. And what I want to say about that is that, first of all, we're sorry for any limitations that exist, and we're doing everything we can, and everybody at the state health department is doing everything we can to expand testing access as much as possible and try to meet the individual needs of programs where they are. And many programs, yours as well as other programs like nursing homes or prisons or rehabilitative facilities or homeless shelters, all of those things, testing access has been a huge challenge. And we think the situation is going to continue to get better. And second of all, that's why these recommendations aren't prescriptive in terms of saying this is how testing will be provided, this testing won't be provided. New resources will constantly keep coming available. We'll try to keep you up to date on what those are. And throughout this document, you'll see a theme is, you know, both preparation and then communication, right? So communication with the local health department, with DDA, with us, as the vehicle for getting access to things that it's a challenge to get access to. And part of our hope is that having a document like this can help improve that communication so that we're understanding what, you know, where it is you're communicating from, what's the basis for the concerns you're raising, and then responding directly based on the recommendations that appear in this document, and also that happening at the local health department level too. So, okay, so that was a long aside talking about preventing and preparing. So identifying an outbreak of COVID-19. So this mostly focuses on screening practices, testing rapidly, and then isolating folks and or quarantining a home during the period of time while you're waiting for test results to come in. Responding to an outbreak, this is really the meat of it. So this talks about all of the measures that come into place beyond just those universal precautions you're taking while preventing or preparing once a single resident or staff person of the home has become positive. And you'll notice a number of these recommendations really focus on just the format for communicating with local health departments, and local health departments will have that this document also. So this can also be their guidance for understanding how it is you expect to communicate with them. Other things here deal with having a plan for what you'll do in the event a resident or staff person tests positive, and that's something we've talked about before, so I won't talk about it again. And then finally, the last two sections of the document deal with discontinuing isolation of residents or staff people. So just talking about what is the CDC guidance for when staff can come back to work and when residents can leave an isolation setting after they've tested positive for COVID-19. And then finally, just explaining how an outbreak ends. And that just tells you when we say, okay, this outbreak is, quote, over, and so you can stop reporting to the local health department. And again, an outbreak is less a statement about there is disease spreading in this program and we're very concerned, and it's more an organizational statement. In other words, when we say there is an outbreak, that means there has been a case in a program, and so we're assigning a tracking number, which we call an outbreak number. That's what we mean when we say there is an outbreak, and so we say closing an outbreak, it means closing out the supervision and support that goes with that particular tracking number. And we're still here as a resource, and sometimes challenges will arise again in the program, and then we would just re-report again and the process would start. So that's really all I have to say. I'm not going to walk through everything on the document in detail because everybody can read it and then come back with questions, but I will pause and see if there are questions or comments folks would like to make now that I can take for 10 minutes or so.
Sure, Dr. Fetter. We did share this with all the audience yesterday, so in the event they had any questions, they can put it in the chat box. So far, we now have seen that there are sites where a person can go to drive-through testing without doctor's orders. Do we still report to the local health departments?
Great question. So this is something we're very excited about, that there are some sites where folks can go to without doctor's orders to be tested. It's worth watching to see where those sites are and if they're able to open in your area. And these are questions that can be directed to the local health department if you're trying to find the nearest sites in your area, or to us or DDA regional administrator who may know more about the sites within your broader region. So if the question is about reporting, the answer is yes, you should still report any positive result to the local health department. If it's during an outbreak and you're completing your line list, anybody who's tested at a community testing site should be put on the line list, just like anybody who's tested through the health department. The only thing that's different is that you wouldn't have to call the health department to request a testing kit, because the testing kit would be provided by the community provider. So yes, any case of COVID-19, or once you have an outbreak, anybody who either has symptoms or anybody who's tested for COVID-19 for any other reason, that should be indicated on the line list that's sent daily to the local health department in the template they provide. And by the way, I just want to say a word on those line lists. They don't have to be a medical record. So really what the local health department just wants is a list of the names of everybody who has tested positive or could test positive because they're either sick or have been tested. So everybody who's sort of involved in the outbreak from start to finish, and then brief indicators about their status. So are they in your home? Are they in the hospital? Have they recovered? Have they passed away? It's not necessary, for example, to continually update the specific symptoms people are seeing. Or if you have a resident or staff person who's unfortunately in the hospital, there's no need to call the hospital and get status updates every single day. We just want to know, is the person in the hospital? Is the person out of the hospital? And if the local health department wants more details than what you're providing on the form, they'll ask for it. But otherwise, it can really be very simple. It's just about keeping tallies of the most very basic information.
Thank you. Some providers have experienced that when they've gone to the drive-through, they were told that they had to be the driver in the car getting tested, not the passengers. And as you know, our group homes have 3 or 4 people living together, so they are going as a group to be tested, or maybe 3 people, and they're being told this. Are you aware of maybe what could be different, or how we can accommodate this type of drive-through centers?
That's a great question. I wasn't aware of that, so I'm really glad you raised it. 2 comments. One is that I'm going to raise it immediately with our point person here at the state in terms of who coordinates the drive-through testing centers. And I don't know what can be done, but I'll at least make him aware of the issue, because obviously we need to make sure that if your residents are driven to a testing center, they are tested. Many of them will not be able to drive themselves. Second is that if you're driving residents to a testing center in a group, if a resident is actively ill, they shouldn't be in a car with other residents. So they would because cars can be a real opportunity for contagion. And if a staff, whichever staff person is driving the residence, would ideally be wearing both a mask and eye protection and gloves. And the reason is because it's a contained indoor environment, and so it's good to have both of those levels of protection. If you're driving residents to be tested, that means you have some concern that they might have COVID-19, and so the staff who are driving them should be using all that personal protective equipment while they're driving in the car. Thank you.
So how do we, as a provider, get a testing kit for an individual who is showing symptoms?
You call the local health department and say, I have a resident in my program who I'm concerned has COVID-19. Can you please provide a testing kit to test that person? They should provide you with one, although you might have to go to the local health department and pick the kit up. In other words, they'll make it available. I would say that these kits are for programs that have the capability to do the specimen collection yourself. In other words, you have a nurse who's affiliated with your program or some other healthcare provider. And I want to add this critically because I also want to apologize if there's been any confusion about that. And that healthcare provider feels appropriately trained to safely collect the specimen. In other words, we're not saying if you have an affiliated healthcare provider, but they're not able to collect the specimen because they haven't been trained, we're not going to do anything for you. We never want to ask anybody to do something that they're not trained to do. So it's only if you have a provider who's able to collect the specimen, then you can request a specimen collection kit from the local health department. And because you're a group home setting, it should be provided for you to do that collection on site, and then you would return it to the local health department. If you don't have the ability to collect the specimens yourself, then you wouldn't generally be requesting the kits from the local health department. You would either be taking the resident to a drive-through program, working with a healthcare provider in your community to come do the collection, or bring somebody to have a specimen collected wherever they need them to be brought, or working with the local health department to request a National Guard GO team to come out to test a larger group of residents in the event that there's an outbreak and you want a larger group of people who are tested. And since I mentioned that, I would just want to preemptively mention that we are aware that there are delays in getting a GO team to go out, that they are not as fast as they were a few weeks ago, and that this has been really challenging for programs. And the goal is to make it as fast as possible, and it reflects basically the growing awareness of and demand for the GO teams, as well as the growing number of missions they've been assigned to by the Department of Health. And so they have many competing priorities, and that is why things have slowed down. And so I apologize for that. And as always, our guidance tries to reflect both what we hope will happen, which is that the teams will come out and be able to do the collection as fast as possible, but also the reality, which is that there can be delays. And so it's important to pursue every option or every possibility that's available. Thank you.
Okay, so some folks are serving children, and they wanted to know if there's any concerns in reference that they should know about the inflammatory virus affecting children. Did you know anything about that? You can expand on that.
Yeah, absolutely. I that is another area I work on. So I think this is specifically about this new sort of rare but severe inflammatory condition that's been identified in children. Is that correct? That's the question?
Yes, that's correct.
Okay, so our understanding of that condition is limited at this point. We think it's very rare. So, I mean, I'm sure many of you have seen, and I'll emphasize that this continues to be true, that COVID-19 is an extremely age-graded illness. You know, older people are at very high risk for serious complications from this disease. Complications and fatalities in younger people are much rarer, and in children they're extremely rare. They're extremely rare. That doesn't mean that children can't contract this virus and spread it to others. We think they can. It just means that they really don't seem to get very sick. Now, there is this new condition that's been identified, this multisystemic inflammatory syndrome in children. At this time, it appears to be very rare. It's not clear that it's caused by the virus's infection at the time of infection. It looks like there might be some lag. In other words, children get COVID-19, and then a while after they actually contracted it, maybe they've even recovered from their initial cold, basically they start to have very, very high levels of what's called inflammation. In other words, it's kind of like their body's immune system kicks into overdrive. And so what you'll start to see are sort of a very high fever that lasts for several days, rashes, conjunctivitis, gastrointestinal problems, all of these symptoms emerging within a very high fever persisting over several days. If you see something like that, first of all, I don't anticipate that most of you will see this. We think it's extremely rare, but we are trying to identify every single case of it in the state of Maryland so we get a better sense of how common it has been. And there have been cases in the state of Maryland. If you see a resident who's running an extremely high fever for several days, who either has been exposed to COVID or might have been exposed to COVID at one point, even if it was more like a month ago, and it's a child, they're having new gastrointestinal problems, they have some kind of rash or conjunctivitis developing, it is very concerning. And you should immediately seek medical attention for that resident. Many of the children who've had this illness have been admitted to the pediatric intensive care unit. So if you have somebody who had COVID-19 or was exposed to COVID-19, they seemed okay, but now they're starting to show these symptoms, even though it's a long time after their exposure or their previous illness, it is important to act quickly. And the key thing, I think, is looking for that very high fever that persists for a full day or a number of days. And one thing I don't know, and I want to be upfront about this, is we don't know if any of the unique disabilities that different residents may have may affect their risk for this condition. So there's no science on that yet. And if there is, I would, of course, share it with this group first.
Thank you, Dr. Fetter. Several of you have asked where can you find the information that he was talking about during the presentation. This was sent out through Constant Contacts yesterday to everyone, but I'm asking Donna Will if she can upload it to the webinar so that you can have it as a handout here. So just give her about 10 minutes to do that. But it also is on the DDA's website, but you should have gotten it through Constant Contacts yesterday. The next question is, if a staff or a person supported is exposed to a positive person and decides to get tested themselves immediately and it is self-test negative, does that mean that they do not need to be quarantined for 14 days, or could they still test positive after the 14 days period?
Sure, that's a great question. And so there's two parts to my answer. The first is that your staff are essential healthcare personnel. And so if they're exposed to somebody with COVID-19, you know, the recommendation is to exclude them for 14 days, but we recognize that's often not feasible. And so it is okay to have them continue to work while wearing a mask and monitor themselves for symptoms and continue to participate in the symptom screenings. In other words, we understand that sometimes it's not going to be sustainable. Indeed, it's often not going to be sustainable to exclude people who are exposed to COVID-19 in healthcare settings, because exposures are more common in healthcare settings. So while there is a recommendation for a 14-day exclusion following exposure to COVID-19, and if you feel you can do that with your staff, then it is the safest choice. We don't require it. Having said as much, if your decision about whether to exclude staff when they're exposed doesn't change if a staff tests negative. In other words, if you would if you're concerned that a staff was exposed and you're thinking of excluding them because they might contract COVID-19 at some point in the future, the fact that they go and get tested and test negative doesn't mean that they are COVID-free. They could still have COVID-19 incubating in their body and just have it not be present enough in large enough quantities for them to actually test positive in the PCR test. And so if they test positive, then they have to be excluded, right? If they test positive, they have to be excluded for 10 days from their positive test date, plus all their symptoms have to be gone for 3 days. And that's outlined in the guidance, and that everybody, I think, is familiar with, that people who test positive have to be excluded. But if they test negative, that doesn't change our recommendation about quarantine. So our recommendations for quarantine are not going to be based on test results, because a person who tests negative can still get sick and test positive later if they've been exposed to COVID-19. So it's a great question, thank you. The answer is just because your staff tests negative right after they're exposed doesn't mean they're in the clear.
So based on that, is there any value to people being tested after they have tested positive?
Yes, absolutely. Two couple of reasons why. The first is you may not have the ability to proactively exclude people after they're exposed to COVID-19. I think the question was, is there any purpose in testing people after they're exposed? So let me make sure So the first reason is because you might not have the ability to exclude people who are exposed. And you might say, okay, I'm going to only exclude people if they actually test positive, because otherwise we would create a staffing crisis. And so then you can catch people who do test positive and exclude them. The second is that the staff person who was exposed in one home may work in other homes. And so if they test positive, you would then know there was an exposure event in those other homes quicker. So in other words, even though a negative test doesn't say there is no longer any reason to be concerned, a positive test does give you useful information. It says, okay, now this staff person must be excluded. And in addition, if they've worked in any other homes, either in my program or another program, then those other homes have potentially had some exposure to COVID-19. And so that would be reported to the health department faster. And if it's in your program, you would be able to act on it faster. And if that staff person worked in another program, the health department would be able to connect with that program, and that program would be able to respond faster. So although out of an abundance of caution, the 14-day quarantine remains the recommendation even for people who test negative, a positive test is definitely still useful, and all other things being equal, getting tested faster is better. And if a staff person tests negative and they get sick, the recommendation would be they go get tested again to see if they test positive that time, because it's not uncommon for people to test negative and then get sick and then test positive.
This is very similar to this one, but if an individual had COVID-19 and has gone through the 14-day recovery period, then gets tested again, the second test also shows positive, is the individual still a carrier of the virus?
It's also a great question. And again, there are two parts. The first is that when a person tests positive for COVID-19, the recovery period is not 14 days. So this is the number one most confusing piece of guidance that we put out there. And so I'm happy to continue answering questions about it. I apologize. When a person tests positive for COVID-19, the recovery period is 10 days from the first day they had symptoms, plus all their symptoms, they need to be recovered from their symptoms. So it's not a hard number. It's you need to wait at least 10 days from your symptoms first appeared, plus 72 hours after you had no fever, and 72 hours after any other symptoms you had are mostly better. So let me present a couple of examples that I think can help explain what this looks like. Suppose a person tests positive. Suppose somebody develops a cough, they get tested for COVID-19, and they test positive. The first day of symptom onset is that first day they had their cough. So their isolation ends 10 days after they first started coughing, unless they're still coughing. If they're still coughing just as much, they need to continue to stay out until their cough is mostly better. Here's a second example. Suppose somebody has a fever. They test positive for COVID-19, and I'm sorry, first they lose their sense of taste and smell, and then they run a fever. Okay? And they test positive for COVID-19. And 15 days out from the start of their illness, they're still running a fever. This can happen. They still need to be excluded, 15, 16, 17, however long it is, so long as they're sick. Once they've gone 3 days without a fever, and any other symptoms they have are better, If they're more than 10 days out from the first onset of symptoms, they can return to work. Now, let me touch on the last point with these discontinuation of isolation guidelines. What do you do when somebody tests positive, but they've never had any symptoms and they never develop any? If a person tests positive and they don't have any symptoms and they never develop any symptoms, then after 10 days from the date their specimen was collected, they're good to go. So if you have symptoms, you wait 10 days from the start of your symptoms, and then you wait 3 days after you get better from your symptoms. If you never had any symptoms, you just wait 10 days from that specimen collection. And this is written in the checklist that was sent out in terms of when isolation can be discontinued for COVID-19.
And
So the question
checklist,
was,
if you just see to your right hand of you of your screen, you'll see that the handouts have been uploaded and you can download. Go ahead, Dr. Fetter.
sure. And let me return to what the actual question was. So I apologize. I wanted to take advantage of that opportunity to just rediscuss the discontinuation of isolation guidelines. The question is, which is an excellent one, which is, what do we do for these folks who meet those guidelines? In other words, somebody tests positive, but now they're 10 days past the onset of their symptoms, and they haven't had a fever in 3 days, and they're all better, but for some reason, they get tested again, and they test positive again, a couple weeks out. Are we still concerned about this person being a carrier? We think no, and we don't impose any additional restrictions on those people. If they get sick, you want to proceed out of an abundance of caution and move them back into isolation, just like you would anybody who's sick. But otherwise, we don't think those people who recover and have no symptoms but continue to test positive for a long time are carriers. Here's why. The PCR test for COVID-19, the test for COVID-19, what it looks for is it looks to see if you have the virus's RNA in your respiratory tract. You could have that RNA in your respiratory tract, but not actually have the living virus in your respiratory tract anymore. In other words, you might not be able to spread that virus to another person and have it continue to grow. The longest that we've been able to show that somebody who has COVID-19 can have that virus taken out of their nose and then infect sort of like cells in a laboratory setting is 10 days, which is why the guidance is based on that 10 days plus not having any symptoms anymore. And in fact, there have now been studies in Korea that looked at people who tested positive, recovered, waited a long time, got tested again for another reason, and continued to be positive. Early on, there was a lot of concern about these people, and they were put back in isolation. Thus far, none of the people who those sort of what they called re-positives had contact with have developed COVID-19. So we were relieved when we saw that, because we think it's more reason to think that probably those folks who get better but continue to test positive for a while are no longer contagious. And so that's why our guidance is all based on that first test result. The most dangerous time for spreading COVID-19 is right before a person develops symptoms and then right when they first develop symptoms. At those times, it's extremely contagious. But for those folks who have the disease and get better and have no symptoms, but continue to test positive like weeks out because they happen to be tested for some other reason, we're not particularly concerned about them spreading it to others. We think it's just these residual positives with the RNA being left in their respiratory tract. This is a new disease, and so we learn new things every day. And I can't say that I'm not going to come back on this phone call some other day later with different guidance as new science comes out. But that is our guidance based on the best science that exists to today, and we really try to proceed out of an abundance of caution with this disease. In other words, if we are concerned somebody might be contagious, we recommend they be put in isolation. And that's not what we're recommending in those cases of re-positives after somebody's recovered.
So this one I'm going to tie together with a couple of, they're mainly related to family, but I'm going to just kind of paraphrase it. So some families, some parents are asking that the agency retest people. So they're saying, what happens, is this needed? The family member wants the loved one to be tested once they were positive or they did quarantine and be retested. Do you think this is necessary? That's the first one.
Not
The other
necessary.
one is the other one is, since we're talking about reopening, and some of the group homes and the residential sites have said no visitors, no family members. They wanted to get your thoughts about, what should they do or how they should handle visitors or coming back, because they want to do weekend visits and also come to the house and visit. So what are your recommendations for that?
Those are great questions. So let me start as the first one, which is retesting. So it's not necessary to do the retesting. That doesn't mean that families, if they can arrange for it, or you if you want to, because you think it's good for your relationship with your families for some other reasons, to do the retesting. Another way you can certify somebody has recovered from COVID-19 is if they have 2 negative tests 24 hours apart and they have no symptoms of COVID-19 anymore. So some people like that because they want to see negative tests. But the recovery guidance that I gave based on symptoms is the one that we require. And it's the one that we want to facilitate access to testing for. So in other words, everything we're doing to provide access to testing is going to be make that initial diagnosis. And so the local health department won't be able to provide testing kits for the purpose of retesting people who are known to have been positive and have recovered. Because if we're recovered, our guidance based on symptoms says they're recovered. And so even if they continue to test positive, like I said, weeks out after their first positive, we're not going to change our recommendations for those people, and therefore we're not going to ask the local health departments to use their test kits for that purpose. So in terms of visitation, so I think when it comes to visitation, if you're going to allow visitation, you want to do it in the safest way possible. So this pandemic could go on for a long time, and the residents of your program need to see their loved ones, and we recognize that. And also, your programs are not nursing homes. They are not, they're not rehabilitative, so they're not designed to be temporary before returning to some other lower security setting. And B, they're not full of residents who are extremely medically fragile. They don't have large numbers of residents. And so the no visitation guidelines we have for nursing homes may not be appropriate for your program. So here's what I'll say. I would recommend that family members not visit your residents in the group home. Because if a member of the community physically comes into the home, this potentially not only exposes their own family members, but also any other residents of the home. So obviously they would need to do the symptom screening to go into the home, but to physically come into the home is probably the highest risk way of doing visitation, because that means, you have a member of the community who has unexposures you're not aware of coming into the home where multiple people live. Another option is for residents to go visit their families. That also carries some risk because the resident, they could be exposed to their family member, and then they could come back to the home. And if the family member tests positive, then they could later get sick and test positive, and there would be an exposure in the home. So just because your resident is leaving the premises to visit their families, that doesn't mean that it eliminates risk of the other residents to the home. So in other programs that have done this, we've talked it through with them, and what they've tried to do is do the visitation outdoors from 6 feet apart. And so just like we're all doing with our own family members or friends or loved ones, for the most part, we're trying to stay home. But when somebody does come by, or if we see somebody else, now the communities are reopening, it should be done in a socially distanced way. In other words, your community is reopening, so people are going to be going out, they're going to be on the street, they're going to be in the park, but you're going to wear a mask, and you're not going to try not to come within 6 feet of those people who you're interacting with on the street, in the park, anywhere else. The same guidelines would go for the residents of your program. If you want to do outdoor visitation, supervised by staff, that's wonderful. if you can do it with physical separation, that's better than doing it without physical separation. In other words, just try to use the same precautions for residents as you would for any member in the community when you're doing those visitation sessions. And I want to emphasize that I'm not trying to say don't do the visitation at all, because we don't know how long this pandemic is going to go on, and your residents need to see their families, and we recognize how incredibly important that is. It's just about thinking through the best way to do it in the most socially distanced manner that's possible for that resident and that family.
Okay, there's one here specifically about the form. And they're asking, why is the temperature in the checklist 100 degrees rather than 100.4?
We probably rounded. I would use did we put 100? I'm not sure if we put 100.4 anywhere, so I apologize if there is internal inconsistency, but if somebody has a temperature of 100, I would be concerned. 100.4 is sometimes what we put in medical documents, but an oral thermometer or an ear thermometer, you know, like one of the ones that use a laser that don't actually touch your body. I'm drawing a blank on what they're called right now. I apologize. Brain freeze. If you're over 100, you want to be concerned. I wouldn't hang too much on looking for that extra 0.4.
Okay, this one is, please elaborate on the example of the person who was retested as positive but symptomatic. Why wouldn't they be back on the path of protocols for COVID positive person? And wouldn't that mean that they are asymptomatic positive? Precautions will still need follow with them, correct?
Okay, so if a person has symptoms, if they're coughing, if they have a fever, whatever, you want to use COVID-19 precautions, okay? No matter how far out they are from the onset of their illness. If they've got one of those symptoms, you want to use COVID-19 precautions. That's true before you have their test results, right? You would preemptively be putting them in isolation while you wait for their test results. It's true after you have their test results. Anybody who has symptoms, you should be taking full precautions. Anybody who has a symptom that could be consistent with COVID-19. So the issue comes up when people get COVID-19, they get the disease, they recover, their symptoms are gone, they've been gone for 72 hours, they're 10 days after the test result, they've met our guidance, but then they get retested again, and they test positive for COVID-19. The question is, why aren't we concerned about them being asymptomatic and contagious? And the reason we're not concerned about them being contagious is because we think that when that happens, when a person gets the disease COVID-19 and they recover, but they continue to test positive, it's because they have some leftover RNA from the virus in their respiratory tract, but they don't actually have the virus in a way that can be spread to others anymore. And that's been borne out both in laboratory studies and then studies of people in Korea who have tested positive when they were sick, recovered, then tested positive again much later. The people who they came into contact with didn't get sick. So it's totally understandable for people to be concerned, and it's totally understandable for people to want those 2 negative test results. But we don't always see it, and we don't want to impose restrictions that we don't think are necessary based on what's been seen in other places. So we know people who get this virus can test positive for a long time. And we're very concerned right before people get symptoms, and we're very concerned when people have symptoms. Once people have gotten better and they no longer have those symptoms anymore, we're not that concerned anymore.
Okay. Should we put people in isolation after they're discharged from the ER visit or returning home after hospitalization? And how different is that when somebody goes to visit a family member for the weekend and comes back to the group home on that Monday?
Sure, that's a great question. So when there's 2 kinds of people who can be discharged from the hospital. There's 3 kinds of people who can be discharged from the hospital. The first is somebody who's hospitalized with COVID-19 and they make a full recovery. And they're discharged because they have met the recovery criteria. Either they've tested negative twice, or they're 10 days from their onset of symptoms and their symptoms are better. They haven't had symptoms in 3 days. those people, when they come home, they can reintegrate right back into the general population in their home. They can go back to their lives with the standard precautions in the home. In other words, if you recover in the hospital, you're recovered. The second group of people is people who are hospitalized with COVID-19, and they're better enough that they don't need to be in the hospital anymore, but they're not better. In other words, they're still coughing a lot, or they're still experiencing symptoms, they're still experiencing symptoms, and the hospital is discharging them because they don't need hospital care, but they do still need health care. Those people definitely should be in isolation because they're still sick with COVID-19. So, and you would want to wait until they've met the symptom-based criteria for discontinuation of isolation. 10 days from the onset of their symptoms, 3 days with no fever, 3 days with their other symptoms mostly being better. The third group of people who can be discharged from the hospital is people who just have to go to the hospital for some other reason. They get sick, they have a problem with a line, they have a fall, and any other reason. So for this group of people, it's tricky, okay, because going to the hospital in and of itself carries some risk for contracting COVID-19. And so for those folks, they don't have to be strictly isolated when they come home, but we do recommend what I'm going to call a 14-day quarantine period. In other words, for the 14 days after they come back from the hospital, it's best for them to try to stay in their rooms or do solitary activities. We wouldn't recommend they visit their families or do anything else in the community during those 14 days. They should stay home during those 14 days. And when staff are working with somebody during the 14 days after they're discharged from the hospital for some other reason, we would recommend they use that full personal protective equipment. So the mask, eye protection, gown, and gloves, because they could become sick and test positive during those 14 days. We don't think it's that high a risk. The hospitals are, well, they do a good job with infection control. So if you're hospitalized with something else, you shouldn't be contracting COVID-19. But it is a potential exposure to healthcare, and so there is some risk. For somebody who goes home to their family, yeah, there is some exposure risk, but I don't know that we're going to say that anybody who goes home to visit their family when they come home to the group home has to do a 14-day quarantine. If you decide you want to do that, you can do that. But I think the better way to think about it, well, not the better way, but another way to think about it is trying to think about how to plan and structure the visits in the safest way possible. In other words, outdoor visits with distancing. If somebody's going home for a weekend to spend time with their families, in other words, they're living in the home with them, etc., I would do some screening with the family first. In other words, make sure nobody in the family has any symptoms that would cause them to be excluded from your home. A resident should be going home to a place where a family member is sick, and also maybe screen to see if they've been around anybody who's sick, because then there's some risk there. And then it's at your discretion, but I certainly think if you decide you want to move forward with a decision to say, okay, you can go home and visit your family for the weekend, but when you come back, you're going to be asked to do a 14-day quarantine. So that means the staff will work with you, use full personal protective equipment, and you're asked to stay home or engage only in solitary outdoor recreation for 14 days. That's totally appropriate if you decide to go that route.
So we have 2 more minutes. This is the last question. And what is the incubation time period after an exposure before onset of symptoms if they occur?
Great question. It's anywhere, it can be up to 14 days. So that's where that 14 days number comes from. So in other words, if you're exposed and you caught the virus, it can take up to 14 days for you to get sick. And that's why the quote quarantine period after somebody is exposed to COVID-19 is 14 days. And that's why we don't use the 14 days for people who are actually sick, because the 14-day guidance is based on what you correctly called the incubation period. So it can be the incubation period can be up to 14 days. On average, it's usually 5 days. In other words, that doesn't mean you wait 14 days and every single time it takes 14 days for people to get sick. It's typically about half of people they'll get sick before 5 days and about half of people they'll get sick after 5 days. And many people, sorry, of those who get sick, many people who are exposed don't get sick at all. Yeah, just because you're exposed, it doesn't mean you're going to get COVID-19. It's not. It's far from certain.
Okay, we are going to be respectful of everybody's time. Dr. Fetter, any questions that was on here that you didn't get to answer, we will flip to you. And then what DDA is doing is we are compiling all the answers for your questions from the last webinar and this webinar, and then we'll be posting them in the website towards the end of next week. So thank you. Have a wonderful holiday weekend and be safe.
Thank you, Sam.